This morning, yet another reminder that the COVID crisis is far from over.
Some new cases are on the rise.
More patients hospitalized for COVID this week than at any other time during the pandemic.
There is little doubt we now live inside one of the most uncertain times in our nation's history. The COVID virus is determined to not only infect everyone in its path, but everything in its path. How we work, how we play, how we learn, live, and love. Every facet of American life has been forced to rethink. Sitting in the crosshairs of it all, we Americans look across for answers from the nation's great refuge, our enduring beacon of hope and healing, our American healthcare system. Rick Pollock began his early career in D.C. back in 1976, working as legislative assistant to Representative David Obey of Wisconsin. He then became a legislative representative for the American Nurses Association, and in 1982, he joined the American Hospital Association. For 40 years, he has faithfully served the AHA, helping elevate the quality and patient experience for American hospitals. In 2015, he was appointed its CEO.
Well, the broader view for the American Hospital Association is, in my view, is we want to be the most influential association in America. And advocacy isn't just about advocating in the sense of representing the members' interests. It's also advocating for change in the healthcare system.
Little did Rick know that on the horizon approached a pandemic that would soon present him with the most significant professional challenge of his life.
When COVID hit, and we're going on literally 2 years, hard to believe.
It's extraordinary.
Yeah, it really is. When it hit, we kind of threw out our strategic plan because COVID was in nobody's strategic plan, right? And we said we got the 3 R's, and then we got the big 3. And the 3 R's were around COVID. And the first was relief, and that was getting substantial financial relief, over $170 billion to healthcare providers to get them through the experience to stay financially viable, and regulatory relief, those waivers, to be able to cut through the red tape, to take quick and decisive action. That was the first R, relief. The second R was recovery. Because remember, there was a time, and in certain places across the country it still exists, where we had to shut down non-emergent services, which creates all sorts of problems in terms of taking care of people that are sick and maintaining financial viability. So we had to find a balance between how do we stay ready for any spike or surge as it relates to COVID, but also how do we keep our facilities safe and encourage people to come back to get the care they need. And then the third R was really rebuilding, which in many ways is the most interesting one. And that is, what are we going to learn from this experience? What do we walk away saying, some of these things we have to reboot, some of these things we have to reevaluate, some of these things we have to reimagine, to think about how we learn to build a better healthcare system. Those are the 3 R's related to COVID. And then we have the big 3. And the big 3, interesting, are 3 issues that we knew existed before COVID, BC, but now just got bigger in terms of challenges. One is workforce and the resiliency of our workforce. The second is behavioral health. And the third are healthcare equity. So that's kind of the way we view the world. We've got these things right in front of us that are right now. And then we have the 3 R's and the big 3. dig out just about anything out of the archives that you can imagine here. And they really, truly are a great asset when you need something that goes back in history and you want to pick it out. We've got a lot of original, manuscripts in here. This is 1996. These are Friday mailings. Every Friday, we would send out mailings to all of the hospitals in the country with all sorts of attachments. This is the Friday mailing from September 13th, 1996. I was with the association back during that period of time. We often need to look back when we're doing things to see what precedents might have been set, what positions we had taken, and all of these things here.
Recruiting and retaining healthcare staff was a top concern among hospitals and health systems long before the pandemic struck. But the workforce challenge has, in a blink of an eye, become even more remarkably vital. Consider, nearly 30% of present healthcare workers are now contemplating leaving their profession altogether, and it's estimated that by 2026, the shortage of healthcare workers will rise to a daunting 3.2 million people. So to workforce, let's pivot a little bit. There's real big concerns. Can you share with us, what's the AHA up to when it comes to workforce? Is that in fact one of the top priorities, which I think you indicated it is, and what are you all doing about it?
Yeah, well, when I talk to CEOs around the country and I say to them, Jeff, I say, what are your 3 biggest priorities? The typical response these days is priority number 1, workforce, priority number 2, workforce, priority number 3, workforce. So yeah, it's front and center. And it's taken on so many different dimensions in terms of what is underneath it. We always knew that there were workforce resiliency problems before COVID, and as I said, they just got exacerbated.
Well, there's no doubt, no people, no ability to serve the people that we exist to serve, which is our patients.
Most importantly, we need to change the healthcare model, the care model, so that people can practice to the full level of their licensure, and that whether it's nurses or whether it's doctors, that they're really doing the things that they're trained for, and that they get the support that they need from other healthcare professionals. I can go through a long list of things that we're involved in that will address some of these problems. The frustration, I think, for everyone is that we have a very urgent problem, and it's not going to be fixed overnight. It's been with us for a while, and we're going to have to stay at it for years to come. But it is without question the number 1 priority for so many, because without a robust workforce, we can't exist.
There is perhaps no leader with a greater responsibility to make consequential decisions than the hospital trustee. Trustees are just that, entrusted by their communities with the duty of care to steward the hospital and its resources wisely. From rural settings to metropolitan sprawls, the hospital trustee plays a crucial governance role, providing guidance to management and upholding the vision and mission of its organization. So this leads me to another question that I have for you, please. So thinking about the different groups that help make a hospital and a healthcare system effective and successful. And one of those groups is our trustees. Right. Trustees are largely, not entirely, voluntary in nature and share their time, treasure, and talent to provide a fiduciary role. What's the life look like for a trustee today and looking forward into the near future compared to maybe 5 years ago? How is that role evolving? And again, is the AHA involved in any capacity to be mindful of that and to be doing things to help elevate success in the boardroom?
Yeah, great question, and an important one, of course, because trustees are, custodians of community values, and they are integral to, how we govern our organizations, and we really value them. And we have trustee education programs that we partner with you on in a variety of different ways as well. So we do a lot in terms of trustee education. But the question that you raise is a really interesting one, is how has it changed? In some respects, in the old days, it was all financial. and it has evolved to go from financial questions to quality issues. And now it has evolved, in addition to quality and financial issues, to issues around cybersecurity. But more fundamentally, it's issues around the future and what will hospitals look like in the future, and how trustees, again, as the custodian of the community's values, will help us shape what the future of hospitals will be. One of the things that I'm very engaged in with our field is what I call redefining the H.
Redefining the H. What does that mean?
Well, you look at the H, and it's an iconic symbol. We see it everywhere. And for many people, the H basically says, follow me, because people know that if they go to that place, it's a place where they're going to get taken care of. Yes. It's perhaps society's ultimate safety net in many ways. And they know that the people that work there are of the highest integrity and ethics and competence and caring. But the H, in many ways, is viewed as a building. And the reality is we're more than a building. And yes, there's a lot of very important things that go on in that building, sophisticated surgeries and diagnostics. But we're having to change to make care more convenient and meet people where they need the care. And we're redefining the H so that we think of it more as a healthcare organization than we do as a building. We're more than bricks and mortars. We're in the home. We're in the community. We're doing things in schools. Trustees have a critical role in explaining that to the public.
Interesting.
Because they're ambassadors to the public. And how we think about what the future is going to be is a place where trustees have to help hospitals, because there'll be changes, and some of those changes have to be ones in which trustees play a role in shaping. What's interesting about this particular conference room, and the reason I take you in here, is because it has on the wall our vision. And our vision is, as you can see here, a society of healthy communities where all individuals reach their highest potential for health. In many ways, you don't see the word hospital in there.
Not at all.
Because we think of ourselves as really advancing healthcare in America in so many different ways. We're more than just a building, even though some important things go on in that building. So that vision statement is one that we keep in front of us in many of the places that we congregate as a team.
I like it.
This hallway here, Jeff, really honors the past chairs of our association, and each and every one of them that I've worked with. So, I've been here for over 35 years, so there's a fair number of them since they serve 1 year at a time. The other thing that you'll see as you walk down here, since we've been around since 1898, is the diversity that finally sort of breaks through. Somewhere in I guess the 1980s or so, where you begin to see more women, people of color, and more diversity, which is reflective of society overall.
The future. I think it's Muhammad Ali that said, "What you're thinking is what you're becoming." What are you, Rick Pollock, thinking about our shared future when it comes to health, hospitals, healthcare systems?
A couple of things. First, the work goes on when it comes to coverage and getting coverage to every American. The ACA was a step forward, no question about it. But even on the day it was enacted, we knew numbers at that point still had a gap of around 23 million people that would be uninsured. So the journey to get to universal coverage continues. And again, as we speak, there are efforts to further expand coverage. There's still 12 states that didn't expand in terms of Medicaid coverage. There are subsidies that are being provided through the ACA to people that are at income levels that weren't previously eligible. So the journey to get more coverage is certainly a part of the future. The second part of the future, in addition to redefining the H that we already talked about, is dealing with the issue of cost, value, and affordability, because we all know that those issues are front and center. And how we improve care at lower cost is something that is integral to where we're going in the future. And we need to do that, and we're committed to doing that through different forms of value-based payment, where we are inevitably moving away from fee-for-service toward different forms of value-based payment, which again have the potential for better care at lower cost. The fee-for-service system doesn't have incentives to really reduce cost because it's driven by volume. And we need to get to different forms of prepayment where the financial incentives are aligned in a way in which it's really about keeping people healthy, and it's really about coordinating care. And frankly, if we don't do it through private sector innovation and different forms of value-based payment, we're going to end up just having rate controls or some form of command and control regulation, and that's not where we want to be.
Anything else about the future, particularly as it relates to traveling through COVID and lessons learned there?
Well, a lot of lessons learned from COVID. One of them is that the supply chain needs to be revisited. Never again do we rely on one country for all of our supplies. We saw the public health infrastructure not perform real well. It's been historically underfunded, underappreciated, and now not very well respected, unfortunately. We got to rebuild, redefine the whole public health infrastructure. We saw telehealth take off.
Absolutely.
And while it can't take care of every condition, there's some utility there in telehealth in providing access to underserved areas. In mental health services, it reduces the stigma if you can do some of that through telehealth.
And do you think that'll stick and stay and grow?
I think it'll stick, stay, and grow, but again, there are limits to what can be done through telehealth, of course.
Yes.
But when you said to the future, the other thing we really didn't talk about that's so important, and it's something that trustees I know are now focused on more than ever, is the whole issue of healthcare disparities and inequities.
Yes.
We knew they existed before COVID. Again, it just made it worse. And I see in the future more clinical, more cultural competencies in how we take care of people, because we're really focused on this issue of healthcare disparities, and so much has to do with understanding the data and having organizational assessments of how we recognize those disparities. We're working real hard through our Institute for Diversity and Health Equity to provide people with the tools to address this problem. America is changing, and we have to be responsive to the people that we serve. And a lot of that means dealing with the disparities that exist in so many ways, dealing with the social determinants of health that affect healthcare status, that differ among different communities. So I just wanted to make sure we talked about that, because I think that's something that trustees are going to be more and more focused on going forward. In our Washington office, we actually have the original ledgers of the first hospital.
Oh, wow.
That was created in America, and it was founded by no other than Benjamin Franklin.
Mm-hmm.
And we actually have his logs on display. For many years, they were in a safe out here somewhere. And one of our previous CEOs said, well, put them out for display. They're not doing any good, even though they're valuable in a safe. AHA News going back to 1997 when we still had newsletters,
Yes.
And it's amazing, I guess, as you look at some of these headlines, Medicare cuts, getting ready for an annual meeting.
Yep.
Here's we're talking about AIDS and teleconferences.
Right.
Wow. I guess we were doing those in 1987. Interesting. When I became CEO, I said I wanted people to be inspired by the work that our members do.